This video describes the minimally invasive surgical approach to retroperitoneal lymph node dissection for testis cancer and has been designed for the core curriculum of the American Urological Association. The contents of this video include preoperative considerations, including patient selection, a case presentation, port placement for robotic RPLND, step-by-step surgical technique, and postoperative considerations for patients undergoing robotic RPLND for testis cancer. Essential preoperative considerations for the robotic approach to RPLND include orchiectomy pathology, serum tumor markers, staging imaging, past surgical history, and prior oncologic treatment. It is generally our practice to target patients who are undergoing primary RPLND for minimally invasive approaches rather than post-chemotherapy RPLND, given the challenges that post-chemotherapy fibrosis can pose to a minimally invasive dissection. In general, for the minimally invasive approach, we target patients undergoing primary RPLND for clinical stage 1B and 2A and B non-seminomatous germ cell tumor in patients undergoing primary RPLND for stage 2A and B seminoma with fewer than 3 masses and masses less than 3 centimeters. We will also consider post-chemo robotic RPLND in select patients with masses less than 3 centimeters. The patient in this case presentation is a 30-year-old male who underwent right-sided orchiectomy with pathology showing teratoma and yolk sac tumor. Imaging showed concern for nodal metastasis with a suspicious pericaval mass less than 3 centimeters. Preoperative tumor markers were normal. Ports are placed at a slight diagonal just below the umbilicus. The assistant port is placed on the side opposite the orchiectomy. Monopolar scissors are used in the left arm, fenestrated bipolar in the right, and a vessel sealer in the fourth arm. Patients are placed in steep Trendelenburg position. All patients receive appropriate preoperative antibiotics and DVT prophylaxis, and all patients undergo a bilateral templated dissection. The great vessels are revealed by incising the posterior peritoneum and heading towards the ligament of Treitz following identification of the ileocolic junction. The inferior mesenteric artery is spared. The duodenum is identified and the peritoneal flap is elevated, revealing the left renal vein as the superior aspect of the dissection. The right ureter is easily identified during this dissection. The posterior peritoneum is tacked to the anterior abdominal wall. Dissection of the pericaval lymph nodes then ensues. Care is taken to ensure control of lumbar veins and to avoid injury to the right ureter. The pericaval lymph node dissection continues by carefully excising the nodal tissue from the IVC using a split and roll technique. Lumbar veins are clipped and ligated as they are encountered. Traction is placed on the nodal tissue as the dissection continues superiorly. The ureter can clearly be seen peristalsing in the background of the surgical field. Specimens are removed via the assistant port as they are amputated from the dissection. Attention is then turned to the medial aspect of the vena cava to proceed with dissection of the interaortocaval nodes. Care is taken at this point to spare the postganglionic nerve fibers as they cross the aorta. Dissection continues superiorly along the aorta to the level of the crossing of the left renal vein. The anatomy is well appreciated during this phase of the dissection. The node packet is sequentially clipped as the dissection continues in an effort to prevent chyle leak formation. The dissection continues with the para-aortic nodes. The left ureter is identified as the lateral aspect of the dissection. The node packet is split over the right common iliac and rolled cephalad to the left renal vein. Lumbar arteries are doubly clipped to ensure hemostasis.
Finally, the right spermatic cord is identified and dissected down to the site of its previous ligation.
The final anatomy is clearly visualized at this point. Surgical snow and tessile fibrin sealant are used for hemostasis. No surgical drain is left in place. The Foley catheter is removed and patients are advanced to a low-fat Kyle-Leak diet on post-operative day 1. Patients are sent home with a 28-day course of Eliquis for DVT prophylaxis. Thank you for your time and attention to this video, which highlights the minimally invasive surgical technique to RPLND for the AUA core curriculum.